Good evening, everybody. I'm happy to be here. Just so you know, I had a little technical difficulty from my end, so I don't have control in the slide. So when you hear me say next slide, I'm not talking to myself. We got somebody helping me here. So if we can go to the next slide, please. So here, just a quick introduction of, so I'm at University of Kansas Health System. I do primary care sports medicine. I'm on the advisory board, medical advisory board for TendoNova for just recently here, and I've been a big fan of the technology so far. I'm also one of the team physicians for the Chiefs. If you hear an accent here, I'm from Montreal, Canada, French speaking, so I can't get rid of that accent. So I went to, my background education wise, I went to McGill University, which is up in Montreal, and did my undergrad there. Then did all my medical school residency in family medicine and sports medicine fellowship, all at KU, University of Kansas. Um, you see a big gap here between the undergrad and the medical school graduation. I had a little hiatus, a little unusual story. I ended up having a 9-year NFL career in the middle of that, and mostly spent most of my time in Seattle. The last couple of years in Kansas City. And if you look at the pictures, I picked the Seahawks one as a uniform because we actually were winning games back then, and didn't win a Super Bowl, got to play in one and had some success. And with the Chiefs, I figured I did way better as a team doctor, which I've been since 2019. Uh, I played for them for 2 years and we won a total of 5 games. So I joke now that they win more games in a month at times if it falls on the right dates than I won in 2 years. So anyway, that's besides the point. So if we go to the next slide, please. So just disclosure, I'm on the advisory board and getting compensated by TendoNova. Okay, next slide. Okay, so really the agenda, what I was going to talk about, first off, talk about how my tenotomy practice was prior to started, knowing TendoNova. I started doing most of you guys have heard of it, 10X back in 2018, I believe. How it evolved when I discovered the TendoNova technology, and then I'll kind of touch about how the way I approach it briefly on how to pick the patients, how to treat them, especially post-procedure based on the type of pathology they have, their age, their requirement, what they're trying to get back to. And I'll kind of explain why I like TendoNova so much, why I think it's tremendous technology. So next slide, please. All right, so my practice before, for those of you that might be in Kansas City area, so I'm with KU Health System. My clinics are at two different areas. One of them is Arrowhead Stadium, so that's the picture right there. We have a clinic there inside the Chiefs practice facility. That's where I do my procedures at. Um, and then I also have an office at the Indian Creek, which is 435 and all in Overland Park. So when I started doing the procedure back in 2018, I was out of fellowship and I was talking with a friend of mine who's a foot and ankle surgeon, and he kept saying, I have nothing for these patients, these chronic Achilles tendinopathy that he doesn't want to do. He goes, surgery, it's a big surgery, the takedown and repair and all that. They're not good options for those types of problems. And I started researching into it, stumbled upon, the tenotomy technology. I started doing 10X. And when I first started in 2018, I was doing, and we'll get more into detail of why it was so, but the way I still do it today, I pick for the most part, I do first Thursday of the month, every month. I block my morning off, and what I do is I do only tenotomies. Okay, so with 10X, the max I could do was four. By the end, five, maybe six, but that was stretching it. As soon as one thing goes a little off, one patient takes a little too long to numb up, or somebody's a little bit late, there's problems with the machine, then we'll go way past lunchtime. The nurses hated it, which, as anybody know here, that practice is when your nurse is not enjoying that day, it's not great, right? So you feel bad about it. It doesn't make everything go nice and smooth. And we'll talk more also about the reliability that I've noticed. Next slide. So how did I hear about TendoNova? So I happen to be on a NFLPA committee. It's called the Mackey White Committee. That's player health and safety is the mission of the committee. And we meet once a year. And there's a bunch of different people on it. Physicians, athletic trainers, there's science people, investors. There's all kinds of people in the sports technology world that's looking at every single thing that make the players' health better. And last year I was at the meeting and somebody brought up that a couple of things that the NFLPA group invested in some new technology, some new groups, and one of them was TendoNova, and it struck me because I already did 10x at that time, and I hadn't heard of it. New company and new product, and ask a few questions. One of the person that's at the meeting and is an investor, and he's a guy that's had a lot of success in that type of world, and that made me kind of look it up. And I still want to know. I happened to go to the AMSSM National Conference in Baltimore this past, I think it was in May or June. Or whatever it was, and I met Jared, who's on the call here. He had a booth there, and then I started, and I could not believe when I grabbed that piece of the TendoNova machine in my hands. I couldn't realize how small and easy it was to handle. No, again, we'll get to that later, but how big the difference was between that and doing a 10x procedure. And I kind of, you had a little silicone piece there. I kind of play with it a little bit. And to me, I thought I was very hopeful. And we started in June, was the first month that I started using the technology. And now, instead of, I told you earlier, I do 4 in 5 cases at most with the 10x in a half day. Now I can easily do 8 cases. And now I even started, since it's so easy to set up, I'll have occasionally, not even on that day that I block off, I'll have an extra patient I'll take in between patients or early in the morning on a different day and just do 1 or 2 cases that want to come in quicker. I found that much more reliable, much more easy to just set that up, do a quick case. Whereas with 10x, if you know it, you kind of had to plan. You had to make it kind of a whole half day because it's too involved and too much of a process to get it going. And the biggest thing, the last line that you see on the slide there is my nurses love it. They absolutely love it. It's easy. It makes their life easy. They still can't, every time we do it, they say, I can't believe it's that easy. And if we go to the next slide, I'll explain why. So this is what it looks like. This is what, if you haven't seen it, so the middle picture there, there's 2 things. The nano thing there, the battery pack, that's what you have. That's what you have in the office. It's on the little charger on the desk. It just charges there when you're ready. That the disposable sleeve, that's the kit that you get for every patient. You slide it on the battery, clicks it in place, and you're ready to go. You turn it on, and it's ready to go. It's again, if you've done 10x, if you've seen it, what a contrast. Okay, and it's very easy to use. And if you look at the far right, the way it works is the actual needle, which is just shy of 3 inches, about 2.85 inches. It has a little franzine tip needle that's a 22 gauge needle. Oh, and by the way, the actual cannula is an 18 gauge needle size. Okay, so you got an 18 gauge with a 22 gauge inside that goes in and out very fast. Don't ask me I'm not an engineer, so I don't know how fast it moves, but um, that's the basic technology, okay? And again, the size of it, how easy it is. Once you're done with the procedure, you take the disposable sleeve, throw it in the trash, and you're done. Next slide, please. And okay, so here's a video. It kind of shows how the procedure works. So first of all, I do a lot of Achilles. So that's an example. Patients laying on their stomach. You use the ultrasound. You identify where the pathology is on ultrasound. Uh, you also, most importantly, find the spot that actually hurts because sometimes they have a big intensified at the end, but that's not where the pain is. You want to go where the pain actually is, mark the spot, and then they went a little faster than I can talk. But then you clean. I use chlorhexidine, clean a big area, put a sterile drape, sterile gloves on. We have a sterile sleeve on the ultrasound machine, and once you get going, this is a picture. This is as simple as it gets. It's like if you've done PRP injection or any kind of cortisone injection, ultrasound guided, it's no different. It's just you have eight. It's like taking an 18 gauge needle, taking it to where the pathology is. So, one of the nice kind of neat tricks about it is if you leave the cannula in there, like they just showed you on there, you can take off the machine and just add a whatever, like a PRP, for example. I use that pretty regularly. At the end of a tenotomy, I just had PRP on there, and you already have the cannula in there. Super easy to do. Um, Again, it's a very simple, if you've done ultrasound guided injections, uh, you should be able to do this without any problems. Next slide, please. Okay, and this is a slide that I've gotten there. I did not make up that slide, and it kind of rates treatment options, from left is mild to right is the most severe, most impressive abnormality on imaging, and it kind of lists treatment options, right? I tend to say, even the very light that's the very far right that tends to say, okay, we consider surgery, or the TX bone, 10X bone, which is one that was kind of sold as being able to dig in the bone. I tend to happen, unless it's a really huge enthesitis in an Achilles, for example, that the pain is exactly on there, then I probably won't touch it and recommend, okay, you probably going to be a patient that needs surgery. But everything else, even if they have big calcification that you can't quite get rid of, I believe, and you go in there and you break up all that scar tissue with the tendonova. And the concept I tell people is, what we're doing is, the way I explain it to patient is you have your fibers in your tendon. They're supposed to all work in sync together. And now you've had chronic inflammation. You got a bunch of scar tissue in there. Now these tendons are all stuck together. It doesn't allow for new blood, new inflammation to come in. So, and even if you do PRP, sometimes it doesn't quite get to the site that you want to get to because all that scar tissue. So, the tendonova, you're going in there, you're breaking up that scar tissue, that unhealthy tissue, and you're causing kind of like a micro bleeding in there, like fresh bleeding, acute inflammation that should heal. And then if you add PRP, that's also a great option. You kind of, double throwing the kitchen sink at it. Um, and to look at these kind of treatment algorithms as it goes, I'm getting more and more. I usually have people do at least 6 weeks of therapy to make sure, but most of the patients that I see, they've been referred by somebody else, and they've done the therapy, the boot, the different injection for, like, for example, cortisone for plantar fascia. And when they come in, I'm a lot quicker to go straight to TendoNova because I just have had so much success. Next slide, please. Okay, so this is just a picture. It's not my actual office, but you can absolutely do it in an office procedure. It's very simple. All you need is ultrasound machine, and literally you saw the size of the machine. That's it. There's no priming, there's no saline bags, there's no like the 10X, none of that stuff. It's very, very simple. And I bill it as an office procedure. My personal structure where I work, I just get paid off RVU. So if you look at the CPT code for these procedures, and you add the ultrasound code to it, I mean, if you do a full morning of this, it's definitely more productive than a regular clinic morning. And as far as the hospital is concerned, they charge, I mean, a hospital-based office clinic. Um, so they build their facility fee, and they're happy, they're making money. I don't know exactly how much, I don't know the exact numbers, but they're perfectly happy with it, and I'm happy with it. So, and the biggest thing, we've never had any issue whatsoever as an office procedure, never had issues with insurance. Um, and obviously you can also do it as in a surgery center, the official procedures suites and all that stuff. People do it, but office procedure to me is more than enough, and it works great. Next slide. And then, so why do I like TendoNova more? Okay, so I've told you about, basically, and I wish we had a picture of the 10X, how big it was, and how you had to, you had the kits came with a cartridge that you had to snap on the machine, and sometimes it didn't snap, and then there's a leak, so you couldn't prime the tubing. It was just a big operation, okay, and the machine was very finicky, and sometimes the I'd have issues with defective probes. Now you saw the picture, it's as simple as it get. And the biggest thing too, if Jonathan, if you can help me here because I don't have access. So the top picture, it's a Haglund deformity. Okay, so distal Achilles. If, for example, when I was using 10X, if let's say the pain in this patient is the Haglund, but it's the very, very distal Achilles, okay, right around there's where the pain is. But they're also having pain all the way up to above the Haglunds. So what I would do, the only option you have is to make an incision right where that cursor is. With 10X, you make a stab incision with a scalpel, and then you have only so much range that you have. You have to fan out because there you only have one port of entry. So you fan out medial, fan out lateral. Very, very hard because I mean, for anybody that's treated this, the insertional Achilles, a lot of time that pain is a lot more distal and a lot more medial or lateral way on the sides than you would think, than you would expect. And getting all those areas is very difficult with a 10X machine. With this, with the TendoNova, I found it like unbelievably better because what I can do is I can still start at the same spot and I'm going straight down distal, like, and I can really see my needle in plane and I'm all staying with the fibers. There's a thought in my mind that if you're going across the fibers too much, you might cause too much damage, which I think sometimes was why I had a hard time with the insertional Achilles when I used 10X. But so I go this and I move it more medial and I go all the way to the very medial, very lateral, and I'm staying down. I can, when I do those, I'll do five, six, even eight different incision spots, but it's not an incision. I'm just needle hole, right? It's like you get an IV, it's an 18 gauge needle, right? It's not, patients come back the first time I did it, I thought, are they gonna look all beat up? They came back at 2 weeks, it looks great. You can barely tell that you poked them before. So so much easier to access all these areas. And then like I mentioned already, the simplicity of the machine is unbelievable and it goes much faster. And again, don't forget nurses are way happier, which is a big deal. Um, Next slide, please. So this is kind of emphasizing the difference between the two, the time. Okay, so if you're looking at it as you've been using 10X, you're trying to see how easy it is, or if you've never done, it's so much easier to get through through your day and get through patients. Now this setup here, they say 10 minutes TendoNova. I think that's realistic. However, that doesn't really account that, the time. I book my patients about 20 minutes, sometimes 30 minutes apart. If I do PRP, it's 30. Otherwise, 20 to 30, it depends. I like to have a little buffer zone so my nurses are not running and I squeeze in other patients, like a quick, easy follow-ups in between while they're turning the room over. So 30 minutes, I think, is a perfect time. Um, it gives plenty of time. Nobody's in a rush because, there's still times your nurse has to put the boot on the patient. And, by the time the patient lays on the table, and sometimes the numbing up takes a little bit more time. And the 10X, I think that's very realistic. I said by the time I was done, I could squeeze every 40 minutes, maybe never be able to stay on time. And that's doing it for 7 years, really cranking. If some of you guys have on the call here have done it quicker than that, you're good. I'm sure it's possible, but that's as quick as I can make it happen if everything went according to plan. Next slide, please. Okay, so then to kind of finish off, I just put a few different cases, kind of highlighting the way I approach it, the way sometimes, especially the post procedure, and quite frankly, my post procedure plans have kind of changed over the year a little bit. I'm really focusing on individualizing all of them because I think every patient's different. They're trying to get a different activity level, pathology is different, and sometimes, I don't make every single patient do formal physical therapy because as you guys know, sometimes copay and people, and sometimes, for Achilles, people have, or plantar fascia, they've done therapy, they know what to do, they can do it at home. Um, so, first case, it's a 66-year-old female, retired, pretty sedentary person, plantar fasciitis for over a year. This is a patient that a lot of times will come and referred to me by somebody else, and they've been put through like therapy, the home exercises, the cortisone, the water bottle massages, a couple of cortisone shots. They get a little relief with cortisone, like most of the time, a few weeks. Uh, they've been in a boot, they've done it all. They come in, they're frustrated. In my opinion, they do, unless they're really overweight, really like badly set up in the first place, for example, really bad flat feet and just really sedentary overweight. Those I'm not that hopeful with. But the average person usually, they do great. I do the procedure. And by the way, the actual procedure itself, usually it's anywhere between 1 minute. I There are certain things like for plantar fascia, I'm not too worried about getting it. I'm not worried about tearing it as much as the Achilles, right? So I'm willing to be until I feel like I've got it all. I Usually it'll take me 3 or 4 minutes, I would say. Uh, and a patient like this I did in June came back at 2 weeks, mild pain. They get out of the boot for short distances at home. They feel pretty good. We get them on the PT. I have a little program. If they don't want to go, if they've already gone, I give them, which basically first 2 weeks you're in the boot, but I get like stretch, just passive stretching for the first 2 weeks. After that, even if they're in the boot for certain other cases, I get them going out. I start with isometric strengthening, progressing to eccentric when it's Achilles, plantar fascia. And like this lady came back 6 week, barely any pain, just first couple steps in the morning or so, and they're happy with it. And that's become more common than anything else that I've seen now with this. It's quicker, it seems to me. The TendoNova has come quicker. And we'll talk about that later. Second case, a completely different case, 21-year-old Division I college athlete, track athlete, jumper, comes in with insertional Achilles for 10 months, right? And you know those people, they're in great shape. They're it's not because they're deficient in their flexibility or strength. They've been working a ton with their athletic trainer. They've maximized that. They've tried, the PT, the dry needling, the prolotherapy, the shockwave therapy, all that stuff. And every time they just can't quite practice at the volume they want to be practicing, and they're struggling with it. And those are the one I tend to use the quote unquote kitchen sink approach. Let's do the let's do the procedure and let's add PRP at the end. Okay, in this particular case, just not too long ago, was back to competing full go. But and those are the ones that keep, like, the insertional Achilles have been the one that I've always kind of thought I struggle with more. It's a little harder to have success with it. I've had a lot more success with TendoNova. Not sure, quite 100% sure why. I have some opinion that I'll share in a sec, but I've changed how I do after. I keep him in the boot 4 to 6 weeks. But having said that, doesn't mean a boot like in a cast, right? I usually, again, first 2 weeks, passive stretching. After that, therapy, especially if they're a college athlete. Let's get going the strengthening, flexibility, and all that. But when they're walking, doing everyday stuff, so, or average person, when they're at work, they're on their feet. Let's say work a job in retail. I want them in the boot for 4 to 6 weeks, and while they're doing all these exercises, and then they come back, they've tend. It seems to me like they've done quite a bit better with that. Again, I don't claim to have all the answers on that, but that's what my personal experience has been. Um, and then this particular athlete, 10 to 12 weeks, like it can do, again, if he's trying to get back to just walking around and working a job in retail, probably would have been fine at 4 weeks, 5 weeks. But we're trying to be a Division I level jumper. That's a lot more demands. Uh, Another case next slide, please. Okay, so this last case here I want to talk about, like plantar fibromatosis. These do extremely well with those tenotomies, in my opinion. From my experience, again, I put two different pictures. The one on the right, the really, really big one. These are the ones I've tried it one time. These are not going to get better. They're putting pressure on every shoe they wear. Those are the ones I tend to have a short leash, sent to surgery. But the ones on the left, that little marble, hard marble you have at a plantar fascia, those I always tell people before the procedure, they're really hard, marble, painful. When I'm done with it, when you come back at 6 weeks, it's not going to be gone. I'm not going to remove it, but it's going to be mushy, less conspicuous, just a lot, just easier. Pain's gone. They do extremely well. And this is like 56-year-old, just an average case, like they've been struggling with it. It's been there. It's gone bigger recently. It's for some reason it's bothering them. They do cortisone, doesn't seem to help. And these are the ones that I quote unquote hammer at them as long as it needs to, because this is not, we're not worried about tearing anything. I want to really make sure I really break up all the hardness of it, all the adhesions, and I've had extreme good success with it. And most people at 2 weeks they're doing pretty darn good. At 6 weeks it's over, and sometimes they don't even show up at the 6 week because they're doing so well. Um, Next slide. Okay, so kind of I've been saying all along, I seemed like I got better results with this. I've done roughly 60 patients, or so I don't have an exact count, but I try to go through it. But since June, and really, my spiel to patient has always been with these tenotomies is, at 6 weeks, I expect you to be at least 50% improved, and it's unusual that people say they're not that much, right? Uh, I've seen, again, this is anecdotal evidence. Now I extremely confident that's going to happen. It's more 75, 80. I get it. It's my success has gone through where I think before with 10x, I think that was a fair statement. About 50% improved, most people, some bit better, some not as good. Now it's very rare to have people that are not happy with it. Very, very rare. Uh, there's less pain after the procedure. I think it might be a few reasons. Might be because it's not quite as traumatic. You know, those 10x, those I think they were about what 10 gauge needle, and they give off some heat, right? So I think maybe the heat damage, maybe I got better with the procedure too. But I really think the fact that the tendon was it's easier to access. You're not going across the fiber. You're not giving it too much damage. Is the way I kind of rationalize it in my mind. Um, and the biggest thing, my hard one I always struggle with was the insertional Achilles tendinopathy. And now I used to kind of dread doing those because I felt like I didn't have that good a success. I think partly is because now, like I showed you on that little picture where we're going with the cursor there, is that I can reach all these spots. Sometimes people will give me my pain's pretty much gone, but I have that spot right there, and they're pointing to just that really distal medial Achilles. Now I can access all these area. I think that's one reason. I've changed my protocol a little bit. Um, and then the other thing is I stopped messing around. I used to try to, these intensifieds, when they're really big, you can't do anything with them. But when they're smaller, I would really go after with the TXP, try to get rid of it, thinking that was going to help. I think it would just hurt people, is my opinion of it. These intratendinous calcifications, uh, where they're not that big, you know, I don't worry too much about him. What I do is with the TendoNova, I put it at the highest setting, the highest speed, and I just go and get after it, and it tends to break up. And it's worked. I was pleasantly surprised that was my one hesitation moving to that technology. Is are we going to be able to use those, take care of these calcifications? And I think it's done better. And I think the important part is addressing all the soft tissue areas around it. And I've been very, very satisfied with it. And then the other thing I'd say is I think it's important, in my opinion, to individualize every procedure, like the protocol after, because every patient's different. They're trying to get to different activity levels. They have different pathology, different, another one I do mostly, I've talked a lot about Achilles and plantar fascia, but I do patellar tendon, I do quad tendon, and recently I've had quite a few lateral epicondylitis, medial epicondylitis. Those do tremendous. Those are I think I'm knock on wood, I'm batting 1,000 on that one because and I think part of it's we don't weight bear on our upper extremities, right? The upper extremities are a lot more forgiving. So people seems to me like I've had a great success with those, um, probably because of that too. So I think that's it. Do we have another slide? I think that's it. Yeah. So I'd love to take some question, chat, or if anybody's got anything there, love to answer them.
Thank you, Dr. Darche. I'm Kelly. I'm the sales operations manager for TendoNova, and I'll be helping out with the Q&A. I've selected some questions from the chat, and if anyone has any additional questions as we go through the Q&A, feel free to add those into the chat as we go. All right, so the first question I have, this is a multi-part question regarding technique, which you just kind of touched on a little bit. But this question says, how long are you treating with TendoNova? For example, what's your average cutting or debridement time?
And that's a great question. And usually it depends on what the pathology is. Like, for example, tennis elbow, lateral epicondylitis, it's a very small area. Usually I'm below 2 minutes on that. It's easy, it's quick, and it's never as quote unquote gnarly as like a distal Achilles or plantar fascia. So it's very easy to get through. Because for those of you that have never done it, is when you get in there and you start breaking up that tissue, it feels really tough. It feels hard, like you have to push, and sometimes it almost like gets stuck in there because all that scar tissue. And then once you go in and out, and after that it gets nice, and now it's nice and soft, and it goes right through it. So to get to that in a lateral epicondylitis is very quick, versus like I did one recently, was a sent to me by the foot and ankle surgeon that already had Achilles repair, like now was having pain, and it was like, hey, let's try a TendoNova on it to see if we can help. I don't know the result yet because it was recent, but then it's such an incredibly thick and scar tissue, like really hard. And I probably was in there for 5 minutes. Okay, that's unusual. But there's so many, it's a huge area that's really hard to get through. And I could have done another 5 minutes. I just, at some point, I figured I might just be hurting the patient if you keep going. And these bigger fibromas, plantar fibromas, I don't think I'm concerned about tearing anything. Achilles, there's always a thought there's only so much damage you can do there, right? You don't want to tear the Achilles. Uh, the fibromas, I just go until I feel like I've hit every spot I can find.
Great. The next part to that same question is, do you prefer to use continuous cutting or shorter bursts?
I end up doing shorter bursts mostly because I'll find an area and I always like to go like have a great view with my ultra. That's what TendoNova allows you. You have the ultrasound, you're in plane with your needle, in plane with your pathology. You get that area, and then when you're done, I'll take it out, I'll move it over and hit that area again. So I get a great view versus trying to always kind of an oblique view of the tendon, but to be in plane with your needle, so you never quite get a great view of where you're at. So it ends up being a bunch of short bursts.
Okay. And then the last part to that question is, what is your approach when inserting tendinova? So, for example, parallel, perpendicular, etc.
As far as like so if I understand the question correctly, usually, so I'll give you an example, plantar fascia. Okay, so I'll have my ultrasound, bottom of the foot, right, like in long axis with the plantar fascia. And I first find my bearings bit by, introduce the tendonova. So I'm out of plane for as far as the needle is concerned with the ultrasound. And then as soon as I'm in there, I flip it to long axis with my needle, so I'm in plane with my needle. So short access to the pathology, I should say, and in playing with the needle so I can really see my needle because I want to make sure I go through the whole plan. In fact, I don't just go halfway. And I also want to make sure I don't go through or I don't start hitting the fat pad, for example, or really
Mm.
irritating people. Okay, I think sometimes maybe that could be a mistake that can easily be done. So I'm really careful. I find my bearings by out of plane, then I switch the in plane, and then I can make sure I get it all. And I go methodically, kind of from first off, I mark off my spot where the pain is mostly, because I only address where the pain is. There's no need to address, maybe just a tiny bit outside of that area, but I address where the pain is, and I go from one spot to the other. And the beauty of this is I can, with plantar fascia, that was a really hard one to do with one incision because you're never having a great view at a great angle. Now I can poke him multiple, five, six, seven times. And again, the first time I did it, I was a little nervous to see how they look at 2 weeks. You can't even tell.
Great. All right. Our next question is, how soon would you consider repeating the treatment?
Yeah, that's a good question. I feel in my mind, if a patient, I guess I should answer by if they didn't have any success with it the first time, I certainly would not recommend to do it again. Only I've had multiple patients that have done it like different body parts or one Achilles than the other one, vice versa. But I've had one person that did extremely well with the insertional Achilles. Year later comes back, the pain's back again. Then I'm like, well, let's try it again. So that was recent. To me, it makes sense. They had a year relief. Why? Their pains that it was more like non-insertional, than it wasn't the same area exactly. Um, so, in the exact same area, I haven't had to do it again. I don't think, being it too short, if you don't have any success with it, it's like if you do a cortisone injection in the knee, if you don't have success, I don't see the purpose of doing it again, right? But if you've had good success and it comes back, a lot of times if they comes back at a different area, then I think it's totally reasonable.
That makes perfect sense. All right. Our next question, they said, I'm a 10x user and I like that it only impacts unhealthy tissue, and B, removes all of the bad tissue. So how does TendoNova address these things?
Yeah, and I think it's a great question. And the way I look at it is, yes, you're breaking up the scar tissue, obviously, right? Which you're doing that with a tendonova, okay? And I get the point, they say, well, the ultrasonic energy, you're supposed to only affect the bad tissue. Um, I don't know how to explain. I think with the tendonova, the actual like damaging the good tissue in a way, like the micro trauma is actually a good thing. That's what we're trying to get, right? So you want to break it up. I think you need it's a mechanical like it debrides it. It's not just like taking an 18 gauge needle and poking around. You got a lot more juice with it. You have the frenzy needle that's going in and out. It feels completely different than just putting an 18 gauge needle in there. And you know, and I'm not saying that 10x is a bad technology because I used it for years, and you know, if I was going to use it, I have to believe in it. But um, I found that and I think maybe the 10x, it's yes, okay, it's ultrasonic energy is supposed to hit just the pathologic tissue, but you're also putting a like 10 gauge needle in there which might be a lot more traumatic to the normal tissue than the 18 gauge that we're using with the TendoNova.
Right. And then our next question is, how do you describe TendoNova to your patients?
So yeah, that's a great question. I usually I when I you know I simplify it. I usually tell people, okay, so you've had this, you've tried all these different things. Now what we're trying to do, you have a lot of unhealthy chronic inflammation, scar tissue in your, let's say, Achilles tendon. Okay, you've even some of them they've tried PRP. We need to PRP. The concept is we're giving you the good cells, the good inflammation that your body naturally has to heal things, right? And sometimes it just doesn't get to the where your pain is because there's all that scar tissue. So what we're going to do with this procedure is we're going to go in there. I'm going to guide it with my ultrasound. And ultrasound, I always show them, look at your tendon here if they want to see it. You know, you show them it's thickened, it's got some hypoechoic areas, it looks unhealthy. And now I show them here, we're going to go break it up. And you break up that tissue, you cause a little bit of like acute bleeding, which is what you want. This is how you're going to heal. I think that's the biggest way it heals. Yes, it removes the tissue, but the biggest thing is causing that new acute inflammation.
Right. All right. Our next question is, what is your treatment endpoint? So is it an imaging change, subjective feedback from the patient, when it feels like it loosens up tactilely to you?
Yeah, I think so. During the actual procedure, it's purely how it feels. Like the important thing is to know where the pain is first before you do it. And I always mark my little spots. And then I want to make sure I find in that area, I really, with my ultrasound, I want to make sure I hit all the areas. And I go by feel. When I feel like it's loosened up, and anybody that's done it, if you've done 10x or anything, it's the same concept. Once you go in there, it's really hard, kind of it gets stuck in there. Then as you go in, it gets nice and smooth. That's what I'm shooting for. And as far as if I get the question correct, the endpoint after that is, you know, I don't repeat the imaging and I don't look for a change in imaging. I don't repeat the ultrasound, let's say 6 months later. I've done it before, but it takes a long time to really make a change. The bottom line is, you know, let's say you have a Haglund's deformity. I tell people it's not going to go away. I'm not going to get rid of it, but I'm trying to get it to not hurt you, which is what we're trying to do.
Yeah. Next question is, would you or do you treat partial tears? And do you have any concerns regarding tender rupture after treatment?
So let's use we keep knocking on the Achilles, but let's say the Achilles partial tear, it depends, right? A low grade tear, like interstitial tear, absolutely. Uh, Depends on obviously what kind of tears, where is it, right? If it's a high grade tear at the very distal Achilles, probably not. But you know, a interstitial mid substance mild tear, they've tried those, you know, you want to try therapy, do all these things, then absolutely I'll treat that. And quite frankly, most of those that I treat, they come from our foot and ankle surgeon, that the ones that come in that have had a partial tear and all that, he refers them out and I usually and it works. I would look at it as unless you have a high grade tear like that's about to rupture, uh I treat it basically like chronic tendinopathy, which is what it is.
Okay, great. Let's see here. Do you ever barbotage after debridement or on any select patient?
I don't. I haven't done it, but it's definitely doable, very easy. Like that little 18 gauge cannula, when you're done with the procedure, you can leave it in there, remove the machine, And then if whatever you want to put in there, you can insert very easily through a big 18 gauge needle, and then you can barbotage. If you want to do that, absolutely. Um, yeah, I've heard people do it. I personally haven't done it.
Okay. And then one last question. Do you like pairing with PRP?
I really do. I usually, especially when they're athletes or they want to come back, for example, like a 40-year-old firefighter that does CrossFit and like really active, once they get back to high level, I tend to recommend it more strongly. And these are people usually that are willing to pay for it because most insurance, as we all know, doesn't cover it. Sometimes they do now, but a lot of times they don't. Those people are more willing to say, of course, I'll pay for it. I want to get back to this. The more sedentary people, they're a lot less willing to pony up and kind of it can be a big expense for people. And quite frankly, there's certain things where I used to think, oh, I want to do like the medial lateral epicondylitis. I used to recommend doing both, but now I keep doing them without PRP, and it seems like they do so darn well that I don't know if it's even needed.
Awesome. All right. So that wraps up our Q&A portion. Thank you so much, Dr. Darsh. And I'm going to send it back over to Ben to wrap everything up.
All right, Dr. Darche, thanks so much for sharing your experience with us and sharing your evening with us after what I would only imagine was a long day. Good luck to your Chiefs this weekend. And yeah, thanks again for being with us tonight. Thank you all for joining us. If your if your questions were not answered, we typically go through the chat. We'll be reaching out. Dr. Darche has made himself available as time permits to answer questions peer to peer, and we're happy to facilitate that as well. Feel free to reach out to your TendoNova rep or to any one of us on the call if you still have questions that remain. But once again, thank you all very much for joining us for the TendoNova webinar. And great job, Dr. Darche. Thank you. Have a wonderful evening, everyone.